This is my partner, John. I'm a paramedic here in Manchester, and John's my partner. He's an EMT. I have been here in Manchester for, wow, almost, I've been a medic for almost 10 years now. And John came originally from Waterbury and moved out here to work out in Manchester. So let me just start. Who knows the difference between a paramedic and an EMT? It's always the toughest one. Anybody? Okay, yes, amount of training, amount of certifications, and what you can do. So one way I like to look at it as is you can kind of look at it as nurses and doctors. So they have different skill sets and different jobs, okay? Paramedic is the highest level pre-hospital care. They trump everybody out in the field pre-hospitally. So nobody out in the field works at a higher level than a paramedic. Below that would be an EMT, an emergency medical technician. So they're typically the partners of a paramedic, or they can also work in an ambulance by themselves. They can have two EMTs that work together. Typically they deal with the less serious stuff. Whenever an intervention needs to be issued, so if something needs to be done to a critically injured patient or somebody that's severely injured, we use a paramedic, okay? So who knows some of the stuff that paramedics can do?
They can like administer IVs.
IVs, so we can start IVs, yep. Anything else? What do we put in IVs? Medications. So we administer medications, right? You guys have all watched, I'm sure, medical shows, right? And they say clear, right? And they defibrillate. So we have cardiac monitors, correct? We can also put breathing tubes in for somebody that's having trouble breathing. We can assist them by putting in a breathing tube and breathe for them. We also, for somebody, say you're in a car accident and you're critically injured and say you have a head injury, paramedics can also administer medications that will put you to sleep, and they can put a breathing tube in you. And then we do a lot of transfers of patients who are critically ill. One of the things that we do mainly is we go from hospitals to hospitals. So a lot of times, say Manchester Hospital, somebody comes in that's really ill, and they need to go to a larger hospital that has the specialists and people that can care for them. Usually a paramedic will take them from one area to another. So that's a huge skill set that we do. The difference in education, usually a EMT course is 6 to 8 months. And then once you become an EMT, then you can step up. After you have a little bit of experience, you can go to paramedic school, which is usually about 2 years long. Luckily, University of New Haven just started a 4-year bachelor's program for paramedicine. It's starting in the US to move on to a degree program. Other states or other countries like Canada have already done it. In Canada, it's required that you have to have a bachelor's in paramedicine before you can practice. So that's one of the things that we're moving on to. So what do we transport? Who do we transport? Anybody, right, that's injured? So the main thing that's really cool about my job and why I love my job is that none of my patients typically are the same. Paramedics have to know a little bit of everything. So we deliver babies, we treat cardiac patients, we do traumas, we do emergency patients, so anything from heat illness, diabetes, anything like that. Biggest thing, other one that we do is a lot of, unfortunately, drug overdoses is a huge thing that we deal with in a lot of the communities that we work in. It's still a large problem. So some of the equipment that we have on our ambulance that we're going to show you guys later, we have our cardiac monitors. Our cardiac monitors we also look at people's heart rhythms, okay, so we can diagnose if you're in a lethal arrhythmia. So normally, everybody's seen that normal wave on the monitor on television shows and stuff. There's hundreds of different rhythms that a heart can go into, and we look at different ones and try to diagnose them to see if they need to be converted into another rhythm, which we use drugs, we use electricity, okay? So a lot of cardiac patients. We do also, with the cardiac patients, we do resuscitation in an ambulance. So if somebody goes into cardiac arrest, we start IVs, we do CPR, we usually put a breathing tube in, and then we try to get their heart back into a functioning rhythm, and then restore a blood pressure on them, and hopefully they can move on and get a cognitive outlook on their, usually the thing that we're trying to save is brain tissue, and keep the brain from dying in that period of time. So one of the things that they're also doing is hypothermia. So we're cooling our patients down to save the brain. So that's for our cardiac patients. Diabetics, we carry different things. We start IVs and we give people sugar through the IVs if their blood sugar drops. What's that?
She's diabetic.
Is she? Don't do that. So yeah, we treat a lot of diabetic patients, and then traumas. Everybody loves traumas. That's a huge one. Everybody loves to do the trauma calls. I'm not a fan. I don't like to see all that gross stuff. What's that?
What is it?
What trauma? So anything from car accidents,
Oh, okay.
yeah, that type of stuff. So we have, the biggest one usually is car accidents. Our biggest population that we actually serve is the elderly community. A lot of falls. They actually make up 80% of our calls are seniors over the age of 60. The lowest that we see are pediatric patients. They don't get sick as easily. And if they do get sick, usually they are able to get to the hospital on their own. We usually don't have to intervene too often. Come on. With pediatric patients. So that's one of the things that I was saying where we have to know a little bit of everything. Just like emergency room doctors, we treat all areas from pediatrics, newborns, all the way up to seniors. And then we have to treat a little bit of all the different areas, any type of emergency that can happen to stabilize. We do work in a mobile setting, so everything that we do, we have to learn how to do it while the ambulance is moving. So there's only two things that we don't do while the ambulance is moving, we always pull over for. That is delivering a baby. There's no reason to be moving. If somebody is actively giving birth in the back of the ambulance, we always pull over to deliver the child. It's not safe to be driving when delivering a baby. And the other one that we do a lot is if we're working on a cardiac arrest and we're shocking them, we usually pull over because what happens is the EKG monitors that we're using to look at the rhythms, they're very sensitive. So actually the movement in the ambulance can give us a false reading. So we want to make sure that we have a good reading on that monitor before we go ahead and do things like give people electricity to try to convert their heart into a normal rhythm. But everything else we learn how to do when we're moving. We learn how to put IVs in when we're moving, how to drop medications, and treat patients on the go. Because our number one end goal is to get patients where they need to go. That depends on whether or not they need to go to a labor and delivery floor. Can a regular hospital, when I say regular, every hospital can treat most emergencies, but there are some caveats to that. For example, if you're having a heart attack, there's only a few hospitals in the state of Connecticut that are actually able to treat heart attacks appropriately. We do, in the hospitals now, they do what's called a PCI. They cannulate the artery in the groin, and they go up to the heart right there during the actual heart attack, and what happens is there's a clot inside there, and they take care of that clot right there and then. Hospitals like Manchester and Rockville can't do that, so we have to take those patients to Hartford Hospital or St. Francis Hospital, hospitals that have the capabilities. Traumas is another big one. We take our patients to mostly Hartford and St. Francis, which are level 1 and level 2 trauma centers. The other small hospitals around cannot care for them. Traumas, I'm sure you guys have heard of the golden hour. You have that short period of window where traumas, the sooner you get them to the hospital and the sooner you can intervene is the better. So that's one of the reasons why we don't sit on scene with those type of patients anymore. We actually get them in the ambulance as quickly as we can, and anything we can get done on the way, we do, but we don't ever delay transport on the trauma patients. We get them to the trauma facility as quick as possible, because typically what's going to kill the trauma patients are bleeding, and it's usually internal bleeding, and the only way to fix that is a trauma surgeon. So that's why we move pretty quickly on them. One area where we're actually going the other way is with cardiac arrests. Right now, when we treat a cardiac arrest in the field, we actually stay on scene for usually 20 minutes, 30 minutes on scene. Because paramedicine has gotten so advanced that when we come on scene and we bring all of our stuff that we're going to go out there and show you guys, everything that the hospital can do for a patient in cardiac arrest, we now can do. So there's no reason to move that patient until we can try to restore a pulse on them. And we'll work them for usually 30 minutes on scene. And then after about that 30-minute window, if we do not get pulses back on that patient, we now pronounce them at the home. And we no longer transport them to the hospital if they're not viable. Where we used to transport everybody to the hospital, that's no longer the case anymore. Where it's a lot more advanced as far as what we do in pre-hospitality, and now they're looking at another level. I'm sure you guys have heard of a PA, right? Mm-hmm. So those are called usually mid-levels. So they're above a nurse and they're below a physician, okay? What's the other, you know what else there is mid-level besides a PA? Anybody heard of an APRN? Okay, so those are those are all in hospital. What they're looking at right now, because the country is having such an issue with the amount of hospitals are being inundated in the emergency rooms and they're overrun, is less transport and more treat and release. So what they're hoping one day down the line is that they're going to make a master's program for paramedicine that will allow advanced practicing paramedicines to do things in the field that don't need to be transported. So if they get on scene and they determine that maybe they just need an antibiotic or maybe they just need a few stitches, we go ahead and we could do that on scene and hopefully treat and release them, which we're seeing coming down the line hopefully pretty soon. They're working on the programs in different areas. So there are some levels that are going to be coming up for different areas in paramedicine besides just pre-hospital care. And then some caveats, paramedics can also work in different areas. We work on fixed wing flight. A lot of that is going to be done with patients who say they're on vacation in St. Thomas or in the Caribbean and they need to get home. They had a major catastrophic incident on their trip and they need to now get home to their family and they've been in this other country for say 3 or 4 weeks. They usually come home on a private fixed wing with paramedics that take care of them on the way. So that's another area that you can work at. Actually, one of my very good friends just got a job and he's been on Lifestar for a while and he just left to go work in St. Thomas. So it's one of his favorite things is he lays on the beach for his 5 days off a week and 2 days a week he flies around taking patients different places. Yeah. And then the other way is on rotator, which you can work helicopters. Here in Connecticut we have Lifestar, but actually there are many helicopter transports in our metropolitan region. Yale just opened up a new helicopter this 2 weeks ago, so now they have a new one. Boston has Boston Med Flight. UMass in Massachusetts, just above us, has UMass, and then there's Albany Med Flight. So there's a lot of flight programs around. Typically, depending on the region, Hartford is one of the different ones where we use respiratory therapists, nurses, which both the RT and the nurse are paramedics. They're double certified for both those. Most of the rest of the country uses one paramedic and one nurse in the back of the helicopter. And then they transport. They have a much harder time with that because they have a lot more challenges that we don't have on the ground. One of the things that they can't do is they can't listen to lung sounds on their patients because of the noise in the back of the helicopter. So if a patient starts to deteriorate and it may be a respiratory issue, they have a much harder time diagnosing these patients. Other issues that arise with helicopters is altitude. There's many things that change when you go up in altitude, oxygens, pressures. So a lot of patients can't be transported by helicopter due to different things like that. So things like, have anybody heard of diving? You get the bends where different gases build up in the bloodstream. Those patients can't be taken up in a helicopter because the different pressures can make those gases expand inside. So they have a lot more challenges than we do up in the air. But it's great because with paramedics, you get to take many different avenues. If you start to get bored after a few years doing ground transport, you can work your way into air. And a lot of people actually work air and then retire into hospitals. Paramedics are a great stepping stone onto other programs.
Come on in, Michael. So I think it's